We have already seen a good amount of information and what is the importance of the basics of mechanics of breathing and your transpulmonary pressure in the last video. In this particular section, we're going to discuss mostly on the resistance and the complaints. So first, you have to know what is resistance and what are the things that contribute to the resistance in the lung. So let us kick on to the resistance first. So resistance in the lung is contributed by two things. One is what we call as airway resistance, and this is the one that contributes majority. Almost 80% of the resistance is coming from the airways only. And the second one, we also have this tissue resistance. Around 10 to 20% of the resistance of the lung is contributed by the tissue resistance. So let us see how this airway resistance will behave. This is typically in the ventilator, we are going to call it as resistance of the airways, RAW. So where R stands for the resistance and AW stands for the airways. And resistance of the airways typically is going to obey the Poiseuille-Hagen equation, because this is a tube with a diameter and there is going to be a airflow through this tube and it's going to behave the Poiseuille-Hagen equation. So this is the one that governs the flow through a rounded or any tube. So Poiseuille-Hagen equation states that resistance is equal to 8 eta L divided by pi r power 4. So where your eta stands for the viscosity of the substance that is flowing. In this case is the air, and most of the time it's not going to change that much. And L is going to be the length of the tube, and again the length of the airways is not something that is going to change a lot. And the only changeable variable here in real time is the radius of the tube, which is going to have a very high impact on the resistance, which means the more the decline in the radius of the tube, more is going to be the resistance, and it's a fourth power relationship, which means 1 unit decline in radius is going to increase the resistance by 4 units. That's the idea. So the real time, the radius is the most important aspect that determines the resistance of the airways. Okay. So which airways is going to have a very high resistance? Typically the conducting zone, number one. The conducting zone is the one that's going to produce very, very high resistance because they are arranged in series. I told you. By Ohm's law, you have studied in 8th standard physics itself, series circuits give resistance and parallel circuits do not give any resistance. So its conducting zone is in series, so you will have a lot of resistance. And if they ask you the zone of maximum resistance is the medium sized bronchi. Among the airways, this medium sized bronchi, otherwise referred to as this segmental bronchi, these are the ones that is going to offer more than 80% of the resistance of the airways. So this is the place of resistance usually. So what are the conditions that increase the resistance and what are the conditions that decrease the resistance? Airway resistance is increased by forced expiration, number one, through a typical process called dynamic airway compression. So definitely we'll discuss about that. And next, you have an obstructive lung disease like asthma or COPD. That is because of the decreased caliber of the airways, and it can be decreased in exercise. Clear? Exercise causes bronchodilation because of that increased caliber. So these are some examples where you can increase the airway resistance and decrease the airway resistance. Typically in forced expiration, you will have progressively increasing airway resistance by a phenomenon called dynamic airway compression. So what do you mean by dynamic airway compression? What is the importance of this dynamic airway compression? So let us take an alveoli. Let us take an alveoli here, so which is nice and tight and is at resting state covered with the pleura. Now we all know at resting state means, what I mean is at a natural resting state at end expiration, that is tidal end expiration. That's a natural resting state of the lung and the chest wall. At this point, you also know very many times we have discussed that it is the place at which the chest wall's outward force will be exactly counterbalanced by the elastic recoil, which means the lung is going to have a non-zero volume at that point, and that non-zero volume is what we refer to as FRC, functional residual capacity, which means it's the natural volume of the chest wall and the lung at rest. Now I'm not satisfied with that. I wanted more expiration. I'm going to try and see whether this air can be expelled out or not. Yes, I can expel to an extent, but not completely. And because we have this typical dynamic airway compression that will come into play and will not allow you to expel the air completely, and you cannot voluntarily collapse your alveoli. Let us see how it works. So now you can see the fact that I am trying harder and trying to collapse the alveoli, and I have tried to collapse a little bit, and this collapse is possible only if I am giving a positive force from outside in the form of contraction of the muscles. So which means now you can see the reversal of the direction of the chest wall force. It's going to act inward now. Let us assume it's giving a pressure of plus 15, for example, arbitrarily. And now this plus 15 is going to act to the airways also, and this plus 15 is going to act on the pleural surfaces also. All the intrapleural areas will become plus 15, and the airways is also going to become plus 15, and the alveoli is also going to become plus 15 now. So now it's not only the chest wall force that is going to act into the alveoli. Another one that's going to also act now, that is the recoil force. Why the recoil force is not acting in the resting state? Because this recoil force was balanced by the chest wall force, and both are in opposite directions. That's why the airway force was 0, because both has cancelled. But now both are acting in the same direction by vector principle. Both will add up on the recoil force as well as the chest wall force. And now let us assume the recoil force is approximately adding to plus 5 in the pressure zone, and the net will be becoming plus 20 now. And you can see here is the resistance zone, the conducting airways. Once they cross that area, the pressure is going to decline. Slowly it's going to become plus 18, maybe plus 16, and slowly at a point it's plus 15. Ultimately, when it's going to reach the atmosphere, it will become 0 when it dissipates into the atmosphere. So one important thing to note is that the airway pressure is plus 15 at this point, and the pleural pressure is plus 15 at this point, and the airway pressure is plus 15 at this point. So this point in the airways at which the airway pressure is equal to the intrapleural pressure, and this particular point in the airway is what we refer to as the equal pressure point, EPP. In this, there is no problem at all, because the pressure is equalizing only at a point where the airways are not even covered by the pleural surface, and it's excellently supported by the cartilage, so there is no point in even talking about a collapse here. But the problem is, I am not satisfied now. I wanted more. I want to try and see whether initially some amount of air has come out. Yes, absolutely yes, because of this principle which I have described, air has come out. But I want to try and see whether I can expel all the air out. So now I am not satisfied, so I am going to give even more excess force, and I am going to shrink the alveoli even more by giving extra force. And again, this is the pleural space covering the alveoli and some of the airways. And you can see now I am generating a huge force from outside the lung, which is coming from the chest wall. So now let us assume the pressure has become 30, plus 30 now. And this will be transmitted all over the intrapleural space. It's going to be plus 30 everywhere. And it's going to be inside the alveoli also. This plus 30 will be transmitted because it's coming from the chest wall. But you can see now the recoil force is not going to be that great, because here the lung has become a little bit smaller now. So you cannot expect the same recoil force, because when the balloon is at this point, the recoil force is more, but the balloon is at this point, the recoil force is less. Now the lung has shrunken because in the last event you have expelled some amount of air. So the alveoli has shrunken, the recoil force is not that great. So let us assume it's only plus 2 here, and the adding upon that you will be resulting in a plus 32. And once again, as you move this resistance airways, this will become plus 31 here, and at a point it will become plus 30, here it will become plus 25, and slowly it will dissipate to become 0 and mixes with the atmosphere. So you can see here also, to an extent you can expel the airways, but one thing that is very important note is that the equal pressure point has shifted now. Initially it was at this point outside the pleural space, but here now it has shifted to airways that are present within the pleural space. And this space, since you reach equal pressures, interpleural pressure becomes airway pressure, and both are also attached with each other, this area tends to collapse. and this area tends to collapse, and this area you will get another site of increased resistance or high resistance. Clear? So I'm not yet satisfied. I wanted to expel more and more and more. Clear? So now let us assume I'm still not satisfied, I want to expel more. And I'm trying harder, and my alveolar size is only this much now. And this is the pleural space. Now I'm giving a considerable amount of pressure from the chest wall side. I'm reaching plus 50. Clear? So now, you know very well, everywhere it's going to be plus 50 in the pleural space. Everywhere it's going to be plus 50 in the pleural space, and your pressure is going to be transmitted into the alveoli also. It's plus 50. But one thing you have to notice, the recoil pressure also will become very, very, very less, which means because the alveoli has become much, much, much smaller now compared to the previous two alveoli, which you have discussed. So it will be only plus 10 or plus 1 here, because we are discussing about plus 2 in the previous, plus 1 here. So you have the resistance airways, that is the conducting airways here, and the moment they cross this conducting zone, the pressure will become plus 50 and even less, 49, 45, and slowly they will dissipate in the atmosphere, becoming 0. And you can see the equal pressure point is now shifted much, much, much lower, and it's immediately after the conducting airways. And you can also see the fact that all these airways will go for severe constriction and severe narrowing, because this pleural pressure itself tends to compress these airways because it's more than the airway pressure. So since you are providing extremely high resistance, it's very, very difficult to expel the air now. At one point, what will happen beyond this, if you try to expel the airways will completely collapse, and you cannot, expel any amount of air anymore. So that concept is the basic understanding of residual volume also. You cannot voluntarily exhale all the air from the lungs and you collapse the alveoli. Not possible at all, voluntarily at least, in a normal lung. So what you have seen is, here, two things you have to note. One, the equal pressure point is coming closer and closer to the alveoli, the more and more you start exhaling the air, clear, through forced expiration. And second point, the resistance area is increasing. Initially in this, we have not seen the resistance at all. Here the resistance zone is very small, but here the resistance zone has become very, very high. And this type of increasing resistance with increasing forced expiration is what we refer to as something called a dynamic airway compression. Clear? I think now you can understand the concept of dynamic airway compression. This concept of increasing airway resistance, because of the equal pressure point keeps shifting proximal to the alveoli, more closer to the alveoli. So since they shift more closer to the alveoli and they shift, because of this shift, your amount of airways that are going to collapse is going to become more and more and more. And the length of the airways that's going to collapse is more and more and more. The resistance keep increasing. That is due to the shifting of the equal pressure point more and more closer to the alveoli. And this concept is what we refer to as a concept of dynamic airway compression. And this also is the basic reason why the more and more you try to exhale, the more and more resistance you are going to get, and more you're trying to exhale. At one point, you cannot exhale any amount of air anymore, and that also becomes your residual volume concept. And residual volume is also there because of your dynamic airway compression only. This fact also explains that one cannot completely collapse the alveoli by voluntary forced exhalation. Very important point. So you have understood this concept of dynamic airway compression. Then let us move on to the complaints. So in complaints, first of all, what do you mean by complaints? By definition, you can tell very easily. Complaints means delta V by delta B. What do you mean by delta V by delta? Delta means change. How much volume is changing per unit of pressure change, which means how much volume is changing per unit of pressure change, and that is what we are going to call it as complaints. But it's very easy to understand a complaints. Complaints is something, ability of some substance to hold something and to keep it intact. It's not like it expands and collapses back. If it expands and collapses back instantaneously, that's an elastic substance. That's not a compliant substance. If it expands and holds at that point, even if you don't give the pressure properly, and that's what we refer to as something called a compliance. And for example, many people do think that your balloon is an example of a compliant structure. Actually, no, balloon is a typical example of an elastic structure. Balloon itself do have some compliance, but it's actually an example of an elastic structure. The best example of an elastic structure will be balloon, because when you expand the balloon and when you leave the pressure, it immediately collapses back. This is elastic. But the best example of a compliant structure will be your polythene cover, where you take a polythene cover, give some force, give some pressure, expand the polythene cover and keep like that. It will keep that shape only. It will not collapse back. And this is what you call it as a compliance. Clear? Ability of some substance to expand and to hold its shape and hold its expansion in that position. That's what we call a compliant structure. So that is what we are actually giving mathematically by this delta V by delta P rule. So if you want to put a curve and understand this, what do you mean by compliance? Let us put the change in the pressure in the x-axis and the change in the volume in the y-axis. Now you can see two substances, two things. One is behaving like this, and you can see another one behaving like this. And which will be more compliant and which will be less compliant? If you see that fact, now you can see this is the change in pressure. Let us assume this is the 1 unit change in pressure. And you can see this substance. What is the change in volume? So this is the change in volume here. This is the point. And this is the change in the volume. For the same 1 unit pressure, see this substance and see the change in volume. And this is going to be the change in volume. Which means by definition, it's very, very clear. The change in volume with the same amount of pressure is more with this blue compared to that of the red. So I can tell this is a very, very compliant structure. And on the other hand, this red color one, I can tell the compliance is very, very less. The compliance is very, very less because the change in the volume for the same unit pressure applied is very, very less with the red color line which I have drawn. So what I have drawn here is typically your artery and a vein. So which is clearly telling you that arteries are elastic structures and veins are compliant structure, because compliance is inversely proportional to elastance and vice versa. Elastance is inversely proportional to compliance. So if you want to write what elastance means, you have to write change in pressure per unit change in volume, which means it resists the change in, how much it resists the change in volume is what we call it as the elastance. So it's exact inverse of what you mean by a compliance. So which means whenever compliance is less means I can tell this is a elastic structure rather than a compliant structure. So arteries are generally elastic and less compliant, whereas veins are the ones that are going to have the highest compliance, which means they expand and they hold. That's what we call compliance. And that is also one reason where your veins are going to act as a reservoir for blood, which means in your body, 70% of your entire body's blood at any point is located within the veins. And that is the reason we call veins are going to be called as a compliant reservoirs, blood reservoirs in comparison with the arteries. So one more interesting association also you can note, if the curves are closer to the y-axis, you can tell the compliance is high. If the curves are closer to the x-axis, you can tell compliance is less. Very simple understanding that you have to know. If the curves are closer to the y-axis, means the pressure-volume relationship, it's going to be more compliant. If it's closer to the x-axis, it's going to be less compliant and it's going to be more elastic in fact. So this is what we refer to as a compliance in the first place. Basic understanding. But this has to be equated to the lung. So the lung compliance. Now, basically lung compliance is of 3 types. You have 3 types of lung compliance. One is called a static compliance. Second one is called a dynamic compliance. And the third one is called a specific compliance. So whenever in exam or anywhere they ask compliance, it always means a static compliance. You have to keep that in mind. But what do you mean by dynamic compliance? It's nothing but a static compliance, and you also measure the resistance along with that of the airways. So this is what we call a dynamic compliance. So it's very simple to understand. So let us first understand what is static compliance, and let us understand what is a dynamic compliance. Let us put a compliance curve for that. Graph, right? So you all know compliance means you are going to put x-axis on pressure and y-axis on volume. So here we can put the transpulmonary pressure change, and here we can put the volume change. Per unit change, increase in the transpulmonary pressure, how much the alveoli is getting distended. I told you here the transpulmonary pressure, when it increases, it distends the alveoli. We saw in the last video itself in a very detailed way. Now you know that the lung and the chest wall is going to have a non-zero volume, and this non-zero volume is called FRC if it's a lung and chest wall together. If it's only the lung, when you take outside and experiment in the lab, that is called minimal volume. That's not FRC. FRC is only when the lung and chest wall are intact. If you take only the lung and keep outside, it is also non-zero volume. It will not become zero. That's what we refer to as a minimal volume. Clear? So now you are inflating the lung. Initially you will get a little bit flatter line, and later on it picks up, and once again it becomes flatter at the end. And expiration is going to be something like this. But you will be astonished by the fact knowing that there are so many things that are happening. One, there is a lot of difference between inspiration and expiration, and this is what we typically refer to as the hysteresis loop. And next thing, the initial area is flat and the later area is also flat, suggesting initially you have very, very reduced compliance, and later also you have reduced compliance. Only the middle part is going to be very, very highly compliant, because that is the one that smoothly goes up, and that is what is going to be more compliant. So why this happens? First thing you have to know that lung is acted upon by a lot of forces, and whenever you are going to inflate the lung, one important force that you have to break throughout the expansion is elastic force. So you have to break this elastic force to expand the lung. So that is something that is needed to increase the compliance of the lung. And second problem is, in the initial region, you also have the surface tension that is acting upon, and that also you have to break, and that is also one reason why your compliance is actually low in this lung initially. Later on, because of complete full distension, beyond that they cannot expand anymore, and that's why the compliance is reducing. That is different. But at the same time, initial part is non-compliant because two forces are acting in the initial part. One is the surface tension that you have to break, and the second thing, elastic force also has to be broken. But throughout the entire expansion, elastic force is going to be there, and you have to break that elastic force also. Fine. So this is the inspiratory limb, this is the expiratory limb. So why you have a different curve for the expiration, which means it's not following the same curve as inspiration. Why it can't go like this and come back like this? Why you have a different expiratory curve? That is because during expiration, there is no surface tension to break and no elastic force to break. I'm not telling no elastic force is present. Elastic force is the one that recoils the lung back, but no elastic force to break, because elastic force is the one that brings it back to the normal location. So you don't need to break the elastic force. And there's no surface tension also while deflating the lung. So that is why you can see the expiratory limb is more closer to the y-axis, which means the lung in expiration is more compliant compared to the lung in inspiration, which is closer to the x-axis, which means it is less compliant. You can clearly see this fact, which I told you already. Lung in expiration is more compliant than the lung in inspiration. Clear? And the difference in hysteresis, they ask you, it is due to the elastic force and surface tension that you have to work upon during the inspiration. That is not present during expiration. But suppose we have not added resistance here. In order to measure the dynamic compliance, you should add the resistance also. Suppose if you add the resistance of the airways, the curve might look something like this. The curve might look something like this if you are going to add the resistance to your equation, which means resistance reduces the compliance a little bit during inspiration, and it might increase the complaints during expiration because of air trapping. Suppose let us assume a COPD patient who was having a very, very high resistance. So let us take an alveolar here and put an extremely high resistance at this point, which means the air to come in, it's very, very difficult. At the same time, the air to move out also is very, very difficult. So this is what we call air trapping, and this patient is going to have a lot of air inside the alveoli. And that is what is complaint. So which means your expiratory complaints is going to increase because of air trapping. But at the same time, your inspiratory complaints, because this you cannot inflate this alveoli properly during inspiration, the inspiratory complaints will actually decrease. And let us see how this will behave. In a COPD patient who is having severe obstruction, your inspiratory complaints will be something like this, and your expiratory complaints is going to be something like this. You can very clearly see this extra region is typically the complaints that is due to resistance, which means this is the reduced complaints. You can see because of increased airway resistance, the complaints has further reduced during inspiration. You can see that because it becomes really difficult for the alveoli to expand, because it cannot expand at all because of resistance, air cannot move in. That's the idea. Similarly, during expiration, you can see air cannot move out, which means the lung is more complaint, which means it holds its volume because air cannot move out. So that's why you can see here, during expiration in COPD patient, your lung becomes even more complaint. It's closer to the y-axis. Clear? So this is how a COPD curve behaves like. And you can also see in a severe obstructive lung disease, they have not reached the FRC. So which means they have to do some additional work to reach this FRC. This is a very, very important area. So which means they have to do some additional thing to reach the FRC back, which means that the air will be trapped, and they have to do that. They have to push with the help of this forced expiration and muscles. You have to do this extra work to come back to the FRC. Clear? If you don't come back to this FRC, then it's going to be really, really difficult. The vital capacity itself will be reduced because there will be air trapping. For example, even though we have not discussed about the pulmonary function test, let us see. You have the vital capacity here and you have the residual volume here. This is the one that's going to give you the total lung capacity. Suppose if your air trapping is too significant, like your residual volume has increased so much, you can see the vital capacity will actually decrease. Even though the total lung capacity may be increased, doesn't matter, but vital capacity decreases as your residual volume keeps on increasing. In severe air trapping, the vital capacity may be reduced. So to reduce this vital capacity, to increase this vital capacity and to reduce this residual volume, you have to voluntarily push this air by using your forced expiration and muscles so that you will come back to the original zone. And this extra work that you do to push it back to your original natural volume is something going to fatigue these patients very fast, and that's why the COPD patients and asthma patients are also prone for type 2 respiratory failure due to fatigue and exhaustion, because you do a lot of extra work. First of all, since the lung is less complaint, which means your work is going to increase during inspiration. Clear? During expiration, you might think lung is more complaint so that work is less. No, not like that. They don't reach the FRC, which means during expiration, normally you don't do work at all. Understand? During expiration, normally it's a passive mechanism. You don't do any work in fact. It comes automatically smoothly back to the baseline. But here they don't reach the baseline at all, which means to push this volume back to the FRC, you need to do an extra work during expiration also. Normally, you don't even do work during expiration because it's passive. But in COPD patient, to come back to the FRC, they need to do that extra work, and that is going to cause massive increase in work of breathing, and that is what is going to result in type 2 respiratory failure due to fatigue and exhaustion very fast. Clear? So this is how a COPD patient will behave. And you can also understand the importance of the dynamic complaints here. You can see this yellow shaded area forms the static complaints, and how the completely, the curve has changed if you add the airway resistance to that, which means when you take the dynamic complaints into account and the airway resistance into account, the curve has completely changed, which means the static complaints is not the same as dynamic complaints, and the airway resistance can completely change the complaints curve. And that is also one reason, if you take an emphysema, it appears as if the static complaints is very high. Because the static complaints is high because the emphysema patients have poor elastic recoil, which means they cannot push the air out of the lungs itself. There will be a lot of air trapping, assuming the lung behaves like a polythene cover. That's why it behaves like, like it appears as if the static compliance is very high, but take the dynamic compliance, it will be very, very low. Why? Because the airway resistance is very high. That will definitely reduce the dynamic compliance. So this is some example of how to understand this static as well as dynamic compliance. And next, one important area where you have a very, very poor static compliance itself. I'm not talking about the dynamic. Dynamic also will be less, but static itself is very poor, is the place called your restrictive lung disease, especially your parenchymal restrictive lung disease like ILD. And another example is ARDS, which is also a type of ILD only, but it's an acute form, but we'll keep a separate name called ARDS, acute respiratory distress syndrome, where the lung will be utterly non-compliant. It's not going to be compliant at all because of a lot of reasons like poor surfactant synthesis and very, very high surface tension. It becomes very difficult to break the surface tension during inspiration because of loss of surfactant in these places. So these are some of the examples of very, very low compliance, which I have discussed in detail in the PFT section. Anyway, so now let us see what is the difference between a static compliance versus a dynamic compliance. Static compliance, it's typically called as stiffness of the lung, which is nothing but a measure of compliance when there is no active airflow. So your static compliance means the test of compliance, that is stiffness of the lungs alone, when there is absolutely no airflow going upon. Whereas dynamic compliance is a test of compliance when there is an active airflow. When there is an active airflow, which means when there is an airflow, you are testing the compliance. That's what we call the dynamic compliance. Remember, very, very simple. If there is no active airflow, you cannot find out the resistance, because dynamic compliance is nothing but if you want to write by the formula, it is static compliance plus resistance of the airways. So how can you find a resistance when there is no active airflow? For example, take this table. This table when it is static, I don't know what the resistance of the table is. I keep the hands on this table, but I don't know what the resistance of this table is. But if I'm trying to push the table along the ground, now I can find out how much resistance my ground is offering to this table for the movement in the ground, in the floor. So only when there is a movement, only when there is a flow happening, you can find out the resistance. Otherwise, you cannot find out the resistance. That is why it is a test of compliance when there is active airflow happening. So here it is a test of compliance when there is no airflow happening. That's how you're going to find out. The formula for static compliance is very, very simple. It is delta V by delta P. Very simple formula. For a unit change in pressure, what is the unit change in volume? So how will you drill in the ventilator? In a ventilator, the static compliance is measured by a formula called, you can write compliance static is equal to your tidal volume, which is the most important change in volume there. The tidal volume is the one that causes a difference in volume, divided by your plateau pressure minus PEEP. Similarly, your dynamic compliance will be change in volume, that is the tidal volume, divided by peak pressure minus PEEP. So these are the formulas. The reason is very simple. Whenever you take a ventilator, they are going to give a standard baseline pressure called a PEEP, and your pressure curves are going to happen along with the, above the PEEP. It's not going to be like a negative and positive. It's going to be fully positive and above the PEEP value only, because the PEEP is the lowest pressure that you can reach in the lung system using the ventilator. So you can see this pressure is what we are going to call it as a peak inspiratory pressure, and this is the PEEP which I have already drawn. And how will you test for the plateau pressure and all these things is by doing something called an inspiratory hold. So let us assume I'm doing an inspiratory hold maneuver. The ventilator will do, the button is there, you press it, which means after the inspiration, the ventilator will just stop the flow. Nothing will happen. Just they will hold and they will stop the flow, and that's what we call inspiratory hold. After the inspiratory hold, remember I told you already, the resistance also contributes to the pressures, which means when you stop the flow, there is no resistance and automatically the pressure should drop a little bit, and still there is some air that is distinct in the alveoli and some pressure should be maintained in the ventilator, in the lung circuit. So this pressure that's maintained even after removing the flow, Once you remove the flow, you remove the resistance. And this is what we refer to as the plateau pressure, which means the difference between the plateau pressure and the peak pressure must be the resistance of the airways, which means, like when you stop the flow, the resistance is eliminated, which means the pressure should drop and the difference definitely must be equal to the resistance. Clear? Pressure due to the resistance. And next, the moment you stop the inspiratory hold, now let us assume inspiratory hold is stopped at this point. Obviously, the air starts moving out due to passive expiration and reaches the PEEP. PEEP is the minimum pressure you can reach, I told you. So now you can see this PEEP to this plateau pressure is the test of compliance of the lung. Clear? So if the compliance is less, the plateau pressure is supposed to be high. The resistance is high, the peak pressure will rise. Suppose let us assume if the plateau pressure increases, which means the compliance of the lung is very, very low. So compliance reduces, the pressure needed to distend the alveoli will be very high. So it's going to increase the plateau pressure. And this peak pressure, remember, is a test of two things. It's a test of compliance as well as it's a test of airway resistance. The compliance decreases or the airway resistance increases, definitely your peak pressure will increase, because peak pressure means you can tell plateau pressure plus resistance of the airways. So this plateau pressure is going to depend on the compliance. So I can tell plateau pressure will increase or resistance increases, peak pressure increases. So when the plateau pressure will increase, when the compliance decreases, which you have seen already. So this is some of the basics of the ventilator circuit that you have to know. So that is the reason why to test for the static compliance, we are using the plateau pressure minus PEEP, which is a test of compliance. Whereas for a dynamic compliance, we are using peak pressure minus PEEP, which means the most important thing that determines the dynamic compliance is both the plateau pressure and the airway resistance, because peak pressure is equal to plateau pressure plus the resistance of the airways. Since plateau pressure means is a test of static compliance, you can add both this together and get the peak pressure, and that is what is going to determine the dynamic compliance. Clear? By the formula. So even though if you still don't understand this, you can see the ventilator topic which you have discussed later on. But anyway, this much is right now is more than enough. Now let us see some of the images that is very important to understand. We have seen this diagrams already, but let us see in an image-based representation. So here you can see the same compliance curve. What I have depicted is only the static compliance curve. I am not told about the dynamic compliance curve. You can see this is the inspiratory limb and this is going to be the expiratory limb. And inspiratory limb is going to be active, and let us assume this is the work done during inspiration, and this is the work done during inspiration, that red shaded area. But expiration, since it's passive, there is no work done during expiration. Clear? So all I've shaded in the red are inspiratory work, and you can see 2 points, the lower inflection point and the upper inflection point. The lower inflection point is due to the surface tension, and the upper inflection point beyond that, there is too much distension. Because of that you cannot distend anymore. So you have an upper inflection point also. This is something you can imagine similar to a balloon. When you take a balloon and we try to blow it up, initial part is very difficult to blow. Later on, when the balloon reaches a small size, it becomes easier to blow further. When it reaches the maximal size also, it becomes very, very exhausting and difficult to blow. So this is what the lower inflection point and the upper inflection point as far as the lung is concerned. Clear? So we are considering the static compliance only in this. But remember, throughout the entire inspiration, you are also going to break the elastic force, which means you also have to do the elastic work. Clear? So which means this work that you have done is based on your surface tension work as well as the elastic work. But one of the most important thing is the elastic work compared to the surface tension work, and this is the work done during inspiration. Expiration, you don't do any work because it's passive. Okay, we have seen about that. So this is one example of a lung with very, very high compliance, because this is how they give the curve. This is a lung with an example of high compliance because you are seeing this curve is closer to the y-axis, you know that. And this is the saline filled lung. You can see that is extremely compliant, even though this is not practical, extremely compliant. It's very, very close to the y-axis. That is because of the complete break in the surface tension. You know that surface tension can happen Only if you take this is the water, surface tension can happen only at the air-water interface. If there is no air-water interface and the entire alveoli is filled with water in the form of saline and there is no surface tension here, and that is why this is extremely compliant. The saline fin lung, it's very easy to distend. And this is an example of how a dynamic compliance is important. You can see here, you can understand that the static compliance curve may look normal, but what you are seeing, because of the increase in the resistance of the airways, you can see a whole lot of compliance is decreased and the inspiratory compliance is much closer to the x-axis, telling it's very, very low compliant. And see the work of breathing. This is the entire work actually done during your inspiration. This is the work done during inspiration. Why? Apart from the elastic work, let us assume this red shaded area is the elastic work and surface tension work you do. Apart from that, lot of yellow shaded area are there, which you are seeing here. These are the work done during inspiration to break the resistance of the airways. To break the resistance, you did a lot of inspiratory work, that is yellow shaded here, and that also adds upon in the dynamic resistance. So this entire thing is the work done during inspiration, which is very, very high. So the work done during inspiration is very high. And again, expiration is not a smooth journey for them, because I told you, even though expiration here it's passive in this particular zone, from here to here it's passive. All right, from here to here it's passive, but see where they left it. They have left it a very, very high volume and they don't reach the FRC. So they have to reach the FRC, otherwise by the principle which I've described already, they cannot increase the vital capacity and next time they'll go for hypoxemia. So they have to try harder, and they have to come back and reach the FRC. At least they have tried harder to come to reach the FRC, which means again you are doing a lot of excessive work during expiration, that is to push them against the normal volume. Clear? So which means there is a lot of excessive work that is done during expiration also. So this is what happens in an obstructive lung disease and whenever there is a excessive airway resistance, and that's what you have to note. So it's not a static compliance alone that is important. You need this dynamic compliance also, and airway resistance also plays a vital role in determining the compliance and the work done during breathing. Obviously, like if your static compliance is low, the work done during breathing will be very high. I'm not telling no. But the resistance also plays a vital role. That's why you have the dynamic compliance. That's why you have to understand the importance of the dynamic compliance. Now, let us see what are the concepts of work of breathing. I don't want to show much diagram. Let us see simple way. Already I have given a lot of analogies. So, what will happen in obstructive lung disease and what will happen in a restrictive lung disease. So, typically work done during inspiration. We'll put work here. Work done during inspiration in obstructive lung disease increased or normal depending on the level of obstruction. If it's higher up, inspiratory work will be more. The more and more you go lower down near the alveoli, the inspiratory work will not be that great. So, but you can understand it's increased by the definition I told you. In restrictive lung disease, inspiratory work is definitely normal. Clear, there is no much inspiratory work that you need to know in a restrictive lung disease, even though the work done may be increased because of the reduced compliance of the lung. If you have a very, very low compliance, you need to have higher work to, break it. So it can be normal or it can be increased as well. Expiratory work typically appears that in obstructive lung disease, it will be increased dramatically, whereas in restrictive lung disease, it is no expiratory work is done because it's a passive recoil only. In restrictive lung disease, there is no active expiration going on. Then you can ask about the FRC. FRC in obstructive lung disease will be seriously increased, whereas here it will be decreased. Then work done per breath. Work done per breath in obstructive lung disease definitely increased because both inspiratory and expiratory work are increased. Whereas work done per breath in a restrictive lung disease may be normal or even appear to be decreased. If they take very shallow breaths, if it's especially a neuromuscular paralysis and all, the work done may be appearing to decrease, or it can be still normal. So, but don't get carried away by this fact. If you take the total work, if you take per minute or per hour, so for a period of time, here definitely again it will be increased, no doubt about that. But here again it's increased. You can ask me, sir, how is it possible you are telling the work done per breath is normal or decreased, then how the total work alone can be increased? It all depends on how they behave. I told you the minute ventilation is equal to tidal volume into respiratory rate. Since the tidal volume may be low, they have to increase the respiratory rate for a long time to maintain the minute ventilation. At the same time, you have hypoxemia in majority of these patients, which will further increase the respiratory rate. So this increase in the respiratory rate may increase the total work of breathing. Clear? They increase the total work of breathing over a period of time. And that is also one reason why this RLD patients, especially these neuromuscular paralysis patients who are going to have low tidal volume, is very, very prone for getting type 2 respiratory failure and muscle fatigue very fast, because they try to increase their respiratory rate, and hypoxemia will increase the respiratory rate further and they may go for a fatigue very, very fast. Clear? That is due to increase in the respiratory rate. So work of breathing is very, very different in a restricted lung disease patient compared to obstructive lung disease patient. But obstructive lung disease patient is very easy to discern it. So it's not a very difficult thing to understand. And the very important next topic, what we have to also discuss is on the time constants. This is a very pretty important area to understand, because especially in the ventilator part, that's what I feel it's important. But let us see what you mean by a time constant in the first place. In the layman's term, you can see like how fast the lung inflates or deflates. You can call time constants in that way, but it's more than that. So the time, a unit of time taken to inflate a particular percentage of volume of the lung, that's what we call a time constant. For example, one time constant is defined as a time taken for inflating or deflating 63% of the volume of the lung. Similarly, two time constants is defined as the time taken to inflate or deflate 85% of the volume of the lung. Similarly, three time constants is defined as the time taken to inflate or deflate 95% of the lung volume, and four time constants is defined as the time taken to inflate or deflate 98% of the lung volume, and five time constants is defined as the time taken to inflate or deflate 99% of the lung volume. So this is what we define as time constants. So why this is important? Because the time constants will depend on two important factors, that is the compliance and the resistance. The product of compliance and resistance, which means the compliance or resistance, if it's going to increase, the time constant is going to increase. Which means even though it's a constant number for the patient at that particular point of time, still that constant number is determined by your compliance and resistance. You have to be very careful about that. For example, the time that is needed to inflate 63% of the lung may be different in a patient who has a normal resistance and in a patient who has a increased resistance. In a patient who has a normal resistance, the time taken to inflate the 63% may be a little bit less compared to a patient who is having increased resistance, where the time constant will increase and the same 63% of the lung to inflate or deflate, it may be a little bit higher. So fine, so understood what is time constant, but what is the importance of this time constant? Suppose if the time constants are very less, remember these time constants are very less means these are the preferred alveoli that will be ventilated in the lung. Number one, these are the preferred areas that will be ventilated whenever the area is having or a lung is having a low time constant. And the second important thing is, if you have a low time constant and if you are trying to inflate for a longer time, if your inspiratory time is high, your inspiratory time constant is low, and you are trying to give a longer inspiratory time, which means they inflate within a short period of time, and you are giving a longer inspiratory time, means there is a risk of injury, especially the barotrauma to the patient, because the pressures are going to increase. So understanding this time constant is very, very important. Low time constant means you have to give a short inspiratory time. If you give a very high inspiratory time, you might result in barotrauma and injury to the lung. Clear? Similarly, if you have a very high time constant, if a lung is having a high time constant, which means they need a longer time to fill up. Which means if you are giving only a shorter inspiratory time, or if you are having a longer expiratory time constant and you are giving only a shorter expiratory time, what will happen? So this needs a longer time to be filled, but you are giving only a shorter inspiratory time, means actually you are trying to reduce the tidal volume. Your tidal volume may be less, even though your tidal volume that you set in the ventilator may be like 500 or 600 ml, because the time is very low for this, is not adequate to fill these areas with high time constants. Your actual delivered tidal volume may be low, so you might end up with hypoxemia again. Similarly, if you have a shorter expiratory time in a patient who is having a longer expiratory time constant, which means this might result in, because they need a longer time to take out air from that area, they are giving only a very short amount of expiratory time, which might result in air trapping, which may typically result in air trapping. And this air trapping can potentially lead to a very dangerous phenomenon in ventilator called autopeep. This is called a stacking of air. At every breath, at the end of expiration, you are not giving sufficient time for the air to come out, so which means air will be locked inside the lung. And with every breath, it keeps accumulating, and after a point of time, the lung will be so much hyperinflated and air trapped that it might expand and even cause a tamponade effect on the heart, and you might result in a hemodynamic collapse, and you might need to enter a code. So you have to announce a code also. You might go to that extent also. That's why this is a very dangerous phenomenon. That's why the adequate expiratory times are again important. So what is the normal time constants that you have to give for inspiration and expiration? Remember, again, the time constant will depend on compliance and resistance. You have to find out the time constants. And in a patient who is on a ventilator, the inspiratory time constant should be at least 3 times the time constant that is during inspiration. The expiratory time constants, again, it should be 3 times the time constant that happened during expiration, which is both are very, 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 very important to understand. Clear? So similarly, let us assume in a very complicated scenario where the same lung is going to have 2 different types of areas with different time constants, one with a area with a shorter time constant and another area with a longer time constant. Let us assume there are 2 different areas with different time constants. So this is something very difficult scenario. This can happen theoretically, but practically very rare. In this scenario, since this area with 2 problems will come, this area is having a shorter time constant, which means this will be preferentially ventilated. Since they are having longer time constant, this will not be ventilated properly, because always everything in the world tends to take a shorter route. So they'll go to the area with shorter time constant, they're not going to ventilate the area with longer time constant, which means this area will be ventilated properly and this area will not be ventilated properly, resulting in this area will be perfused properly. This area also, if it's perfused properly, means you are ending up with a VQ mismatch. If there is no problem in the perfusion, means this area will be ventilated better compared to this area which is not ventilated, which means you will result in a VQ mismatch in an area with high time constant, resulting in a hypoxemia. Clear? About this VQ mismatch, we have discussed in detail in the respiratory failure section. So go do watch that. And second problem which can happen in patients who are having, let us assume this area with a low time constant and this area is having a very higher time constant. What's going to happen is, suppose initially you start with inspiration, the ventilator is delivering inspiratory breath and the air is moving into this area preferentially, and air is also moving into this area also to some extent. But now what will happen is, now everything would have reversed. Now the ventilator is now starting to give expiratory breath, which means now this area with shorter time constant will be in expiration. But remember, this area is having a longer time constant. Already we know that blue shaded area, we saw that. And this is going to produce, this is still in inspiration, which means it has not even completed its inspiration, but the areas with shorter time constant have started its expiration already. So what might happen is, this air, instead of moving out, might move back into the areas which are still inspiring. Clear? So this air may be diverted to areas which are still inspiring with increased time constants. This movement of air that is coming from areas with shorter time constant to an area with larger time constant, or it can happen vice versa also. Movement of air from area with increased time constant to area with shorter time constant is what we refer to as pendulum, which means the air is moving between the 2 areas with different time constants. That's the idea. That's what we call pendulums. The movement of air between 2 areas with different time constants in the same patient, in the same lung, is what we refer to as pendulum, which means they rebreathe the same air again and again and again. Again, they will result in hypoxemia and death. So this also should be addressed. That is why it is very, very important to understand this rule. For an adequate good inspiration, you need to give at least 3 inspiratory time constants, and for a good expiration, you need to give at least 3 expiratory time constants. And the time constants, a lot of modern ventilators do measure on their own, and they adjust the inspiration and expiration, but still you have to be very aware of the fact, even if the ventilator fails, nobody should fail. So I think you can now understand the importance of the time constants. With this, we can stop your basic lung physiology lectures, and with this we'll be moving on to the PFT lectures in the next section.